Hello, students. Welcome to an overview of therapeutic communication in nursing. When we talk about therapeutic communication, what is it exactly that we're referring to? Well, we're talking about communication that's patient-centered, so it's focused on the needs of the patient. It's also goal-directed in that the patient is expressing something to us and we want to provide supportive responses that will ultimately meet the needs or goals of the patient. It's also based on science. The techniques that we use to enhance the nurse-patient relationship are based on research into communication between providers and patients. So what we're trying to do is we're trying to learn how to recognize statements that would be supportive of a patient, that would strengthen our relationship with that patient, and that would ultimately support their recovery. And we're also trying to recognize statements that we may want to avoid that might start to break down that nurse-patient communication. So we're not trying to say that on a multiple choice therapeutic communication question that there's only one way to speak to a patient. We don't all walk around as robots using the exact same language. But what we are trying to do is recognize things that support patients and statements that break down that support. Now, what are some of the benefits of using therapeutic communication techniques with patients? If we do it correctly, very likely the patient will feel like they can trust us. They'll feel safe in the environment where they're being cared for. And what that translates to is a situation where they trust us enough to express any doubts that they have, to explain things to us that may help us to help them. For example, if they notice that a certain pill that we're about to give them is a different color than the one they got yesterday at the same time, this patient may feel able to better express or to fully express their doubts and may help us to avoid a medical error. If the patient feels like they are not being respected and the communication is not good, they may remain silent. They may not tell us this important information. So ultimately, if we build that relationship through using therapeutic communication, it will enhance patient outcomes and speed up recovery rates. Now, how do we learn more about therapeutic communication other than through lecture or the textbook? One way is just like in a lot of areas of nursing where we can look back and say, okay, that scenario didn't go exactly like I planned it. Wonder what I could do moving forward. Learning from our mistakes is a very valuable exercise to help us with therapeutic communication. Seeking out a mentor, like in many other areas of nursing, like skills that we may perform on the patient. Mentoring can be a great way to bounce your ideas off of someone with more experience. And even if you don't have a formal mentoring relationship, if you just listen to the way that an experienced nurse or doctor or other provider may talk to their patients, sometimes you get some great insight into what it takes to build trust and rapport with a patient. And then finally, just like learning from our mistakes involves looking at ourselves, taking the opportunity to self-reflect, to think about what are our strengths and weaknesses? What are potential situations that I could get involved in that might make me feel uncomfortable? So for example, maybe I know about myself that I might feel uncomfortable communicating with patients who are experiencing psychosis, who are not in the reality that we mostly share. With that knowledge and that self-reflection, I can seek out resources specific to that situation. There are various models that describe the communication process. Now, granted, as nurses, we are unlikely to encounter an NCLEX question about models of communication. We're not linguistic experts, but there's still a couple of good points to learn from looking at just a couple of the models of communication. One model that we can look at is the transmission model of communication. This is a very simple model in that communication is basically described as a one-way process. You have the sender of the message. That sender has a thought in their head and they encode it. They put it into words and they send it to a receiver or recipient. The receiver decodes the message. In other words, they hear the words and they assign meaning to it. And then in the background, we have other things that might be going on that might interfere with the message. Noise. But that's a pretty simplistic model. And so the transactional model is one communication model that we look at to figure out how communication works in the context of two people having a full conversation. What this does is it describes communication as a two-way process. And it describes us as whether we think we're the sender of the message or the receiver. Communication is almost always involves us being a sender and a receiver sort of at the same time. And what this model also does is it factors in context, particularly this one down here, the relational context. So let's look at this a little more. So we have a person sending a message, and we have a person over here on the right that might be the receiver, except that the receiver is also sending messages at the same time. Let's say that you're telling a certain story, and the receiver of the message, the other person, has a disgusted look on their face. Well, you as the sender are also receiving information by that facial expression that tells you, I wonder if I should continue on with this story, right? If I should keep sending this message. So really, our verbal and nonverbal cues make it so that communication is almost always being sent both ways. The relational context is important because essentially what we know is we use different words, we use a different tone with our boss than we would with our friends. Also, in the relational context, every time we send a message, verbal or nonverbal, intended or unintended message, that message has the ability to either enhance the relationship between the two people, or it has the ability to break down or damage that relationship. So everything we do with a patient is being interpreted sort of in real time. Now, what are some specific factors that can really affect communication? Well, one that we see, particularly in psychiatric settings, is the mental health of the patient. So we might have a patient with bipolar disorder, and their thoughts, because they're currently in a manic episode, their thoughts are very fast. And we might go right next door to that patient and have a very depressed patient. And that patient might be so depressed that they're barely speaking, little, if at all, speech. Cognition is another thing that affects communication. So your ability to think in that moment definitely affects the way you carry on a conversation. And we're not just talking about IQ here or intellect. It could also be that you are experiencing a mental health condition such as psychosis. And along with your psychosis, you're hearing voices. Well, your IQ is normal, but you're hearing voices that are so intrusive that it affects your cognition, your ability to think. So very often those patients have great difficulty carrying on anything other than very basic communication during their episodes. Language or cultural barriers. That's very common sense, right? If you're speaking in a language other than your preferred language, you're going to be able to express ideas maybe not quite as well. We'll talk about how culture affects communication here in just a second. Also, though, we're looking at the level of equality in the relationship. So like we said, we may use different words, gestures, a different level of formality with our friends than we would with a work supervisor. Also, this setting impacts communication a lot. If I'm trying to interview a patient and I'm in a common area with no privacy and a loud television and extremely bright lights, those are all factors that are going to affect the amount of information that I can exchange with the patient. Verbal and nonverbal communication is important to understand. When we say verbal communication, we literally just mean the words. It's not even how the words are spoken. It's just the words themselves. Verbal communication can tell us about someone's beliefs, their values, their perceptions, what they see in the world or what they see in a certain event. It also puts meaning behind thoughts. We have to be very careful to consider when using our words what exactly we are communicating. Hopefully, if we're talking to a patient, we're indicating interest and understanding. If we have some missteps along the way, though, we might indicate something like insult or judgment. Also, by what we say, are we showing that we're authentic people? Or do we come across in a more condescending or distorted manner? Now, nonverbal is all the other ways that we communicate things to people other than the actual words that are expressed. So, tone of voice, the emphasis. You can have a sentence that is, maybe 7 or 8 words long. And if you put the emphasis on a different word each time you say the sentence, see how the meaning of the sentence changes. Facial expressions play a big role in sending our message to a patient. Body posture, we generally strive when speaking to a patient for an open posture. So things like folding our arms in front of our chest may indicate that we are not ready to have an open conversation. It may come across to the patient as cold or rude. Eye contact. And we'll talk about this a little more in the discussion of cultural considerations. But eye contact in some cultures can indicate authenticity, a genuine person who is expressing the truth. And then hand gestures also play a huge role. If someone says something to you, and then they say the same message, but they're pointing their finger in your face, I think that shows you the importance of how important these gestures and other nonverbal cues are. Something that you will run across in discussions of communication is a situation known as a double bind. This is different than the the double blind term that you'll run into in evidence-based practice. Double bind is basically a situation where somebody puts you in a no-win situation. They are giving you contradictory messages, two messages expressed with the same idea, and no matter what you say back, it's probably going to be wrong. And these happen, we can look at our personal life, we can look at work settings, we can look at the hospital with patients, but I'll give you a couple examples of what a double bind is. The statement, so in a relationship, one of the people in the relationship might say to the other, "You never buy me flowers." Well, really, after that statement's made, partner number two, it really has no correct action to take. Nothing they do at that point is going to be right. If they run out the next day and buy flowers, then partner number one just says, "Well, you're only doing that because I told you to." But then if they don't go out and buy the flowers after they've been told, "Hey, you never buy me flowers," then they come across as cold and not listening to their partner's needs. Another classic example is when someone tells you, "Be spontaneous." The idea of being spontaneous is that you come up with your own things to do, your own ideas, and you just do them without being told by another person. So the whole concept of being told to be spontaneous by someone else just doesn't make a lot of sense. Double bind situations are difficult, and sometimes you don't necessarily know how to respond. So using active listening techniques can help. So if we're going to prepare for therapeutic communication, prepare to be good active listeners, there's an acronym, SOLER, that we can use to remember all the things that we need to remember. So we're going to sit facing the patient at the patient's eye level. If you've ever had a conversation with someone while they're standing and you're sitting, you see how quickly that becomes very awkward. The person who's standing may be sending the message of, "Hey, I have other places to be," and it doesn't make for a very good rapport. Open posture, as we mentioned earlier, is another important one. The L is lean toward the patient. So if you've ever asked a patient an important question, but you're in the patient's room and you've got one foot about to leave the door, and you just don't look like you're engaged in the conversation, it's very likely that you won't get the most valuable information from the patient because they won't trust you. Establish intermittent eye contact. And again, we'll talk about eye contact with cultural concerns, but when we give eye contact, we don't want to turn things into a staring contest, turn things uncomfortable. And then the R in this acronym is relax. And here's an important point to keep in mind. Patients can tell when a nursing unit is on fire. The unit is really busy. Things are short-staffed. The patients all have a lot of needs. The way you respond to that really comes through to the patients, and they can tell when their nurse is stressed. So you do your best when you're having these interactions to relax. Your own attitude toward your tough, busy day, your own response to stress can impact your patients and how they respond to the day. So, using questions in therapeutic communication is a key strategy. Typically, we like open-ended questions. Questions like, "Tell me a little bit about what it was like to grow up in your family. Tell me a little bit about what's bothering you today." Those are open-ended questions that give the patient a wide range of things that they could talk about. A closed-ended question can generally be answered with a yes or a no, or a one or two word answer. So they can be good for seeking specific information, but they aren't so good for getting your patient to open up to you. Projective questions, this is basically using things like word association. If I say a certain word, what do you think that means? Or what word comes to mind in response? Projective questions are used more by psychiatrists, psychologists, psychotherapists in counseling sessions, typically not in nursing. There's something called the miracle question, which basically when you ask the patient, if you were to wake up tomorrow and all of this family stress that you're experiencing was magically, miraculously disappeared, what do you think would have had to change in order for that to happen? What things would be different if this problem went away, or what would have to be different in order for the problem to go away? Now, I just told you open-ended questions are typically what we lean on in therapeutic communication. But if you have a patient with difficulty in their cognition because their mental health is so bad that they can't think through an abstract question, they can't think through something that's going to require a detailed response, it may be that that patient will benefit from these short, closed-ended, very simple questions. Sometimes where you might experience that would be a patient with very high anxiety, a patient having a panic attack. I'm not going to ask them a multi-step question because they're so focused on what's happening to them that they can't really give me a detailed response. Patients that are manic often have difficulty slowing down their train of thought. And psychotic patients. You can imagine if you were hearing voices or seeing things or experiencing delusions, that it might be very difficult for you to answer a detailed question. So we're going to look at some specific therapeutic strategies, some things that are good. So when you're answering a multiple choice question about what do you say next to this patient, you'll learn to recognize some things that could be helpful, that could get the patient to continue talking to you. Accepting is very simple. It's not saying what I think what you're doing is good, but it's simply getting the patient to continue talking to you. Something like just nodding your head. That's a form of accepting. Saying, go on, I'd like to hear more. Giving recognition. So what this is basically, you notice that the patient did something. So in the patients that I work with, hygiene, because of serious mental health problems, hygiene can be a struggle. But I might notice that as a patient wakes up, they comb their hair and they brush their teeth. I might say something like, I noticed you combed your hair. I'm not going to say something like, your hair looks really nice. That falls under what we call cheerleading, which we'll talk about as a non-therapeutic strategy. But I can say something like, hey, I'm noticing that this happened. It shows that we're paying attention to the patient. And hopefully it will allow them to think about how to continue that behavior. Offering self. Offering self just means that you are willing to stay with the patient. It's your presence. So prior to entering psychiatry, I worked full-time in the NICU for many years. And sometimes there are situations that come up in the NICU that are so terrible, such as trying to support a family through the loss of a child, there are very few things that I'm going to be able to say to that family that will put any sort of Band-Aid on their grief. But I could say something like, do you mind if I sit with you for a while? Would it help you to have someone to talk to right now? I'm here if you need me. Doing something like offering them a Kleenex. Giving broad openings. So essentially this is asking a very open-ended question and just giving the patient a chance to talk. Something like, what would you like to talk to me about today? Placing events in time and sequence. This is helpful as a clarifying technique. So a patient is telling you about a bunch of things that happened in their life, and you're trying to figure out how it all fits together. So you might ask the patient a question like, okay, so the fight that you had with your partner, did that happen before or after you got confronted by the police? Making observations. It's very similar to giving recognition. You're just noting what you see. I might have a patient who's very isolated, withdrawn. They aren't getting out of their room. And then one morning they come to the desk and they ask for toiletries and they're practicing self-care. I might make the observation, it looks like you have more energy today. And then the patient can tell me, oh yeah, I slept for several hours. And we can talk about how to continue that. Encouraging comparison. So often patients who are going through stressful times have been through previous times where they were stressed out. Or patients who have lost someone or been through a crisis. Maybe they've been through a previous loss or previous crisis. How they handled that previous loss or crisis, that is very important to know. And so we can start figuring out what works for this person and what might not work. Maybe they can use some of the same coping strategies they used the last time around. So that's the comparison. This event versus the previous event. Restating is basically taking a description that a patient gives you, taking a situation they tell you about, and after they tell you, you sort of put it in your own words, just to make sure that you're understanding. Reflecting is very similar to restating, but you're trying to get at the feeling that was expressed. So instead of restating the fact that, okay, so you guys argued and then he yelled at you and you yelled back and then you left the house. Reflecting might be something like, sounds like you guys had a really big fight. Confrontation. This one we have to use with a lot of care. It has to be the right time. Confrontation is basically the patient has told you something that conflicts maybe with something that you know about the patient or something they have previously told you. And you want to bring up that inconsistency. Let's say a patient tells you, oh, my drinking is not that bad. But on your admission assessment, the patient told you that they had 3 DWIs. Now, I'm not going to use confrontation in the orientation phase, right? Pre-orientation, I haven't even met the patient. Orientation phase of our relationship, when we're just barely getting to know each other, if I use confrontation too much, it will break down the relationship. But once we're in that working phase, I can actually have enough rapport with the patient to bring this up. Focusing. That's when the patient has told you about a bunch of things, but there's one thing in the very middle of what they're saying that's very significant. So the patient tells you, I woke up and ate breakfast, and then I went in the bathroom and cried about how my life is a total failure, and then I went out shopping and out to eat for lunch. So that really important thing is kind of stuck in the middle of all these other details. And you say, okay, for a second, what I'd like to do is focus you on this period where you felt worthless or you felt like you were very depressed. Tell me a little more about what led to that and what that was like. So it's sort of pulling out the significant details and asking the patient to tell you a little more. Summarizing is basically, it's very similar to restating, but it's taking a lot of information and putting it into a simple statement. Presenting reality. So this we use a lot with patients who are psychotic, patients who have auditory visual hallucinations or delusions, these sort of irrational thoughts that aren't based in reality. And so I'm not going to argue with the patient, but if the patient tells me, hey, there's a little green man in the corner of my room, I can tell the patient, I've checked your room very thoroughly and I don't see the little green man. And I want you to be safe while you're here. So I'm keeping an eye out on things. That's presenting reality. Encouraging evaluation. So getting the patient to answer, how do you think that behavior worked as far as trying to get closer to your goal of going home? It's getting the patient to evaluate themselves. Voicing doubt, again, not something we use a lot in the orientation phase, but so I once had a patient. I went to the same college as this particular patient, and our college's football team has only won the football national championship one time, and that was in 1939. This patient was born in the 60s, and she was telling me, she said, I know it sounds crazy, but I was at that game. I was at that national championship, and I know you're going to think I'm nuts because how does that even work? And so I didn't want to say, you're crazy. You need to live in reality. How could you think such a thing? That would be showing disapproval. But I just voiced a little bit of doubt. I just said, I wonder how that works. That you were born in the 60s and you attended something in the 1930s. And so it's starting to plant that seed that will allow the patient to start thinking about what is reality and what isn't. Verbalizing the implied. So a patient tells you a story and it's all about how they're very depressed or sad. But they don't ever use the words depressed or sad. And so I, at the end of their story, say, wow, it sounds like that made you really sad. Exploring. So this is very similar to focusing. A patient tells you something and you want to know more about it. And so you say, oh, sometimes you have feelings of overwhelming anxiety. Would you mind telling me a little more about what you experience? Suggesting collaboration. Hey, let's you and I work together on a solution to this problem. I wonder if we can come up with some ways that you can deal with feelings of anxiety. Encouraging formulation of plan. That's very similar to suggesting collaboration. It's just you're getting the patient to come up with their plan. Seeking consensual validation. That's basically saying, let me make sure that I have this right. It sounds like what you were experiencing felt like this. And that allows the patient to tell you, yes, you're right on the money, or no, actually what I meant was this other thing. Giving information. So we do this a lot. Patient asks about their medications, and I tell them about side effects. Or seeking clarification. You might say something like, when you said this, I wasn't exactly sure what you meant. Can you tell me a little more about what you mean by this particular phrase? Now, some roadblocks, some non-therapeutic techniques, things that we generally don't want to use. Giving advice is generally not within the role of the nurse who's practicing therapeutic communication. It seems very natural to want to do that. But very often we don't give the patient enough credit. Usually if we communicate with the patient and they hear themselves saying certain things, they can often come to the conclusion that they need to change certain things in their life. The only advice that I might give a patient would be something that has to do with patient harm. Like, no, I don't think you should cut yourself, or let's come up with some alternatives when you feel like overdosing on your pills. Another one that sounds very natural, and you think, well, how could you even have a conversation without this word? Asking why questions. The reason that we want to avoid why is because why questions run the risk of putting a patient on the defensive, making the patient feel defensive about the things they've done in their life. And so if I say something like, why are you depressed? The patient may feel judged by that question, right? If I say something like, tell me more about the things that led up to you feeling this way, that's a much better answer or question to pose without using that why. Asking excessive questions. This happens a lot when I get a psychiatric patient who's here for an admission. They just came to the unit and I have a screening assessment with loads, dozens of questions. And this person is tired and irritable, and they've already answered the same questions at the outlying hospital and in our admissions department. So what I have to do is basically ask the questions that are essential to this person's safety. And maybe I can ask the rest of the questions in the morning after this person gets a few hours of sleep. Minimizing feelings. So these are basically, it could be a lot of things that you do that could minimize feelings, but it's basically telling a patient or suggesting to a patient that they shouldn't feel the way that you feel or the way they feel. One thing we sometimes do that could minimize feelings is we're taught in customer service training to do what we call managing up. We talk about our colleagues, the people that we work with, in a positive light so the patient trusts them. Minimizing feelings, though, where that comes in. Let's say that a person says, I don't feel like my doctor is listening to me. And my response is, oh, you have an excellent doctor. He's great. Everybody likes this doctor. Now, I can say, have you met this doctor yet? I think he's a really good doctor. But when in that moment, when they're telling me, hey, I don't think my doctor's listening, if I come back with, oh, you have an excellent doctor, it makes it sound like I'm telling the patient, your feelings aren't valid. So in that moment, that's not the right answer. In that moment, I would say something more like, tell me more about your specific concerns with the way that your doctor talks to you. I'd like to see if I can do something to help. Disapproving or disagreeing. Well, I don't know why you did that. I would have done this other thing, right? So that's something that we have to watch. We may not agree with every action our patient takes, but we have to maintain that relationship so they'll trust us enough to help us help them to get better. Changing the subject. Oh, I don't want to talk about that right now. I'd rather talk about this. Well, the patient wanted to talk about the original subject, and that's why they said what they said. So try to follow it for a bit. Making value judgments. This can really break down relationships if we're not careful. So I'll get it as an example. We serve patients who come from all walks of life. You may have a patient who identifies as LGBT or as transgender. They have a right to identify in that method, in that manner. And regardless of how that jives with your personal values, at that moment, you are serving the patient, right? You're trying to enhance your bond. So if you come at the patient and say, that doesn't align with my morals, that kind of value judgment is going to make it so the patient doesn't trust you. Now, giving approval or cheerleading, giving approval, that seems like the most natural thing to do in the world. Earlier, I told you about giving recognition or making observations, and I gave an example of, I see that you fixed your hair. I see you combed your hair, would be a better way to say it. What I'm not going to say is, wow, your hair looks so nice, right? I'm going to give a more neutral statement because the patient may not want that kind of attention from me. A lot of patients, especially in mental health settings, have histories of things like sexual trauma, sexual assault, sexual abuse. You can see how maybe a nurse telling the patient that they look attractive may not be the kind of attention that they're seeking. Also, if you can give the approval, in one moment, the patient's thinking, well, gosh, I wonder what they thought of me when I came in here and my hair was completely a mess. So it's just best not to go there. You can give neutral, supportive statements without turning into a cheerleader. False reassurance. Again, seems very natural to want to tell the patient that everything is going to be okay. You might be treating a patient who has struggled with schizophrenia for 15 or 20 years. So if you say something like, oh, we're going to get you all fixed up, you're going to be feeling better in no time. I'm sure this is the last time that you'll ever have to come to the hospital. Those are all examples of things that the patient knows is probably not necessarily true. We want to reassure the patients, but if it's false reassurance, we're not going to fix them right up. An inpatient admission for schizophrenia is probably going to return the patient to a certain baseline. It's going to help them get past a crisis. It's not going to fix everything. And then using cliches. If you could get the phrase that you're using, if you could take it out of a novel, or these sort of, it goes along a lot with giving false reassurance. But if you're throwing a saying at the patient, you just want to make sure that it's genuine and not just a cliche that you're using. Other things to avoid. You don't want to argue with the patient. You don't want to try to do psychoanalysis, right? Interpret what they say or speculate about, I think what might be going on is you didn't have a very good relationship with your mother when you were growing up. Well, if they've specifically told you about that, then you can make that observation. But if that's just coming out of your speculation, that's not helpful to a patient. If a patient starts to talk about another patient or talk about a certain staff member, regardless of your own opinions, the professional thing to do is to stay out of that and encourage the patient to move to a different topic that doesn't involve attacking others. It makes us as nurses look pretty unprofessional when a nurse joins in on that sort of thing. Probing. So going into sensitive areas where the patient does not really want to discuss. It's one thing if a patient says, let me tell you about this thing that happened. This comes up, well, you may know a patient has a history of sexual abuse. You're not going to ask for the details of what exactly the patient went through because most people don't want to talk about that specifically. And you're not a trained psychotherapist that would be able to really process that with a patient. Another thing is trying to sell the patient on treatment. Gosh, this would be so much easier if you would just take your meds, you could go home. That's just going to break down any relationship that you have with the patient. Focus on building rapport, offering the prescribed medications or group sessions to the patient, and letting the patient make their own decisions. How does culture impact? We've referred to it a few times. Different cultures have different communication styles. So something like nodding the head. If a patient is nodding at you, it's not necessarily indicative that they know exactly what's going on. They may be nodding out of a sense of respect, not wanting to upset you. It may not mean that they understood a single thing you just said. Eye contact. So I was raised, my dad thought it was very important to make eye contact with people and give a firm handshake and, these sorts of things. There are people, and sometimes it varies by culture, who find that disrespectful and intimidating. And so eye contact can be intermittent. It's not a staring contest. And you always have to use your social awareness as a nurse. And if something's not working, you shift to something else. So look for those nonverbal cues that the patient may feel uncomfortable. Touch is another thing that can be very culturally relevant. In mental health settings, regardless of culture, we tend to minimize touch. I might do something like give a patient a fist bump. It's a good way to indicate to the patient that I'm not afraid to touch them, but also that I don't want to do something that could be seen as threatening or inappropriate or traumatizing. So something like a hug in a mental health patient, that's generally not something I'm going to do. Because many of these patients have that history of sexual trauma. And some sexual trauma patients may not even tell you that that's what they've been through because they have shame about it. And so what we don't want to do is unintentionally further the trauma with someone. Cultural filters. Those are things basically by looking at things through the lens of the culture where we grew up, we can sometimes make assumptions that lead to bias. And so it's not about what I think about what the patient says or does. It's more about asking the right questions, finding out from the patient, what did this mean to you when this happened? And finally, process recording. So process recording is an exercise that typically it's what we do in school, in a lab setting, something like that, where we have an exercise where a nurse and a patient are talking to each other, and we create a written record as close to the actual conversation as we can that records the words of the patient and nurse. And then what we can do is analyze, okay, when I said this, the patient responded by leaning back and appearing surprised. And then the patient got very quiet. So maybe what I said put the patient in an uncomfortable situation. And you can reflect on, well, maybe next time I would say it this way, in a way that encourages the building of that rapport. Thanks a lot. One of the important things to remember as you think about therapeutic communication is the number one reason why patients don't seek mental health care, they don't seek psychiatric help, is societal stigma, right? So there's a stigma around seeking care for mental health concerns. And so by the way that we communicate with the patient, we can either make them feel trusting of us, or we can make them feel even more stigmatized. And so by doing things that don't make the patient feel defensive, that by being willing to listen and making the patient feel accepted, we can further the patient's willingness to get help for particular issues. Thanks a lot, everyone.